What are some tips for difficult IV starts? What's up, everyone? Welcome to the Daily Sean. For those of you who haven't been here before, my name is Sean. I do a daily video on something related to nursing. No rhyme or reason. Probably not going to change. Tips on difficult IV starts. Another segment from my Hey Sean series, YouTube Live. A little bit late. Sorry, gang. Had a difficult week. Difficult as in long. So doing a Hey Sean segment a day late, my bad. It happens. Welcome to nursing. I had my first week back in the 12-hour shift setting, and it was a rough one. I'm not going to lie, a little rough. So here I am a day late. My bad. It happens. Answer another question from the tribe. Had an interesting question from one of the tribe members asking about difficult IV starts. And I need to disclose that I don't do much IV starts these days, but back in the day, as an ICU nurse, I did a lot of them. A lot of them. So I did pick up a few things that might help you when it comes to starting an IV. Or should I say, cannulate. Got to make sure we use the proper term. Cannulate an IV. Let's start with what we consider easy. An easy IV access is right there in the AC. It's you could do that one blind almost 90% of the time, unless you're trying to start an IV on dehydrated grandma that hasn't had food or water in days and was found down, who has, I don't know, renal insufficiency and is a difficult stick. The AC, usually going to get it most of the time. 90% of the time, you could close your eyes and you can stick the AC. The go-to place after that is probably the hand, although the hand kind of sucks for the patient, and the hand can be a little difficult depending on the size of the patient. Probably the easiest one after that is somewhere in this area. Those are easy. And the most easy are those healthy, young, athletic patients that have veins for days. Those are the easy ones. You could drop a 16. Even if you dare, you could drop a 14 in there. For those of you that don't know what I'm talking about, the size of a catheter, the IV catheter, it correlates to a number. And the lower the number, the larger the IV. So the larger the circumference of the IV. So a 22 is itty bitty small. 24 is even smaller. And a 16 gauge is almost like a pipe cleaner. So standard numbers are 18, 20, and 22. That's in the adult world. In pediatrics, it's a whole other ball game. I'm not even going to go down that road. So what's a difficult IV stick? Difficult IV stick has to do with, first of all, you can't see the dang IV. So it could be a patient who is of colored origin, who is not Caucasian, who might have a tint to their pigment. First of all, those are difficult to visualize and see. Second kind of difficult patient or difficult IV stick are the patients who are obese. Karen, a couple people are climbing in on the feed, and Karen, who's from Australia, says that she has a doctor and all they want are 18s. And that's all fine and dandy. That's a wonderful place to live in, but then there's this thing called regality. Had Dave out in the live feed asking, notice nurses scoff anything higher than a 20 gauge. Well, it's because there are a lot of medications and fluids that we can't give through anything smaller than a 22, meaning anything smaller than a 20. So 18 and 20 are ideal. 22, there is evidence out there that says it can damage or it can, what's the term I want to use? I don't want to say it makes it ineffective, but it can damage blood cells, more specifically platelets and blood cells. So ideally you want to put blood and platelets through a 20 gauge. 22 gauge you can, but there's some weird evidence out there that suggests that it actually damages. It's too small, but I think it's just a nursing urban legend, to tell you the truth. The other reason for wanting the larger bore is that you can't give fluids at a faster rate. So if you want to give fluids wide open, you want to give fluids, if you want to pound the fluids in because someone's hypotensive, you can't do that through a 22 and a 24. It's kind of impossible. Look up Bernoulli's law that has to do with the circumference of a cylinder and the length of a cylinder. The longer the cylinder is, the harder it is to pour fluid through that cylinder at a fat rate. And the smaller that cylinder is, the harder it is to pour fluid or any kind of dynamic element through that tube, and that tube happens to be the IV catheter. So it's one of the reasons why whenever someone comes in as a trauma patient, you want to put in 18 gauge needles or larger. It's back to the difficult IV stick. So you have colored pigmented skin, you have the obese patient, and the last but not least is the dehydrated patient. Big surprise there. Dehydrated patient means you have someone who has their veins are completely collapsed. So someone who is properly hydrated, their veins are going to be nice and plump. You're going to be able to see through that, okay? Someone who's dehydrated, who has low fluid volume, veins are collapsed. Pretty self-explanatory. Pathophysiology 101. So trying to stick a needle or a cylinder, the IV, into a collapsed vessel becomes a bit of a challenge. Oh, boss, welcome to the live feed. A couple more people coming in through the live feed. This is a unconventional time of the week. Normally do it on Friday nights. Unfortunately, life got in the way, so we're doing it on the next night. Talking about difficult IV sticks. Talked about what's easy location-wise, as in your AC or in the hand and sometimes along the brachius. Difficult IV sticks are colored pigmented skin, the obese patient, and the dehydrated patient. The obese patient, of course, it has everything to do with too much adipose tissue between the outer layer of the skin, external, to the environment, and where exactly the vein is. Only other kind of difficult IV sticks I can think of are just anatomical challenges. Someone who has scar tissue, someone who has a broken bone, has wounds everywhere, or they have inability to use a specific limb because of surgery. Someone who has had a mastectomy, someone who has an AV fistula, you're not going to be able to use that limb. So that makes things, quote unquote, difficult because you can't use that limb. Here are a couple things that you can do to increase your chances for IV cannulation success. First thing you need to do is that you need to practice on the good veins. You need to practice on look and feel. Look, feel, and location is what I would suggest. So when you have that patient who has beautiful veins, when they have veins for days, you want to take note where in location those are on the arm, location, how they look, and how they feel. Feel is the most important sense, is the most important assessment skill you're ever going to have when starting IVs. because there's going to be many, many, many times where you're not going to be able to actually physically see the vein. The vein is not going to be readily evident. It's not going to be sticking out on top of the skin completely in view. Many patients don't have the vascularity that you want or you desire as a nurse. So you're going to have to go on a search and rescue mission for a vein. And the best way you're going to find a vein is through touch, through feel. So when you finally get the patient that you can see a vein, it's engorged because of their wonderful vascularity, close your eyes and actually feel the vein. Palpate it. Run your fingers along, up and down, so you can get it for feel what it feels like. Because once you start to hone that skill and sharpen that skill, when you're not able to actually see a vein, you're going to be able to utilize that sense to access and find a good vein. For instance, you have a patient who comes in who is African American. She is in her 90s. She's dehydrated from vomiting for several days, and she hasn't been eating much. So she has the trifecta. She's dehydrated, she's got the pigmented skin, and she's elderly. So, I mean, this is one of those horrible scenarios where, oh my God, how am I going to start a vein? You're going to have to start utilizing look, feel, and location. Looking to see if you can actually see anything. Location, know exactly where the veins should be. I say the word should. Should be. Because after you do IV sticks for a long enough period of time, you know that they run along the borders of your ulnar area, or they have some that are along the thumb, around in the hand area. Knowing that some will run along here, you can have some along the forearm, and, you know, of course, the AC. The next thing you want to set yourself up for success is, of course, using the tourniquet. The tourniquet is going to help you. Caveat, don't do the whole tippity tapping. That doesn't work. I don't know where that came up. I think people watch one too many Hollywood things, too many TV shows, too many movies. Anyone who starts IVs on the regular should know that slapping a vein, slapping someone's arm, does nothing except piss the patient off. It's not going to make the vein pop up out of the skin. Negative, Ghost Rider. Not going to happen. Want to put the arm in a dependent position in some way, shape, or form, if you can. Have the tourniquet on the arm, and then have the arm dangle alongside of the bed for, I don't know, a minute or so. Try and engorge the vein if you can. After you've done the tourniquet and you've put the limb in a dependent position, you should also try and heat up the area if you can. If you can't, it's understandable. One of the tricks that I used to use when I used to think I saw a vein or I felt a vein is that I would take an alcohol swab and run it up and down the area. Run it up and down the area a couple times and create a little bit of friction. Great way to clean the skin, first of all, but create a little bit of friction, and it actually sometimes will help. I don't know what exactly the physiological response is to it, but sometimes the vein would become more readily accessible. It would show itself for a split second, or it would engorge enough that you could see it. I think it might have something to do with, you know, running your fingers along the valves. I don't know. I'm making it up, I guess. Last but not least, another IV cannulation skill tip that I would use is making sure you have taut skin. Making sure you're pulling the skin where you're going to access the vein. You're pulling that skin towards you. So it's pulling the skin and then making sure that you are at the right angle when accessing the vessel. You're going to make sure you're at that 30 to 60 degree angle. That 90 degree angle, that ain't happening. Somewhere around 30, maybe 45. everybody has their own tips, or everybody has their own way of doing it, technique. So someone asked in the live audience about that wandering vein. So it's that vein that keeps rolling. They call them rolling veins, and it's a physiological just abnormality. It I can't explain why. The rolling veins is pure anatomy, and if you utilize the technique that I said about pulling the skin taut, pulling it towards you, that will help anchor things down. I don't know how well it does it, but it always seemed to work for me. It will make the vein disappear slightly. So if you were to take a 18-year-old athlete and you find a vein, you see the vein, you clean the area, and you pull the skin taut, the vein will I don't know, disappear a little bit, but it will hold things down for you. I wish I could tell you why it works. I only know that it works. So give it a try. If I had to think of any other kind of techniques, or any other tips that would help with IV cannulation success when it comes to difficult IV sticks, is that I would simply ask the patient. Flat out ask the patient, have you had an IV started before? Where have they found success? Is there an area on your hand and your forearm and your, upper limb? Is there any place that you found success? Or better yet, you ask them when they got blood draws. Did they use the right or the left? And it's just pure anatomy, and quite honestly, you want to go where people have been successful before. You got to remember, at the end of the day, IV cannulation, IV starts are purely dependent on practice. 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 Let me say it again. Practice. It's like anything else in nursing. The first time you do it, you are going to stink. You're going to stank. You're going to suck a lot. But you need to be diligent and be stubborn about it. Keep practicing. Keep trying. Don't do it at the expense of your patient's comfort. Meaning, if you tried once, you might get a second shot. You're pushing your limits when you've stuck the same patient 3 times. You're pushing your limits. I think every facility has at least a rule or guidelines that 2 is probably the limit. If you've failed twice, maybe it's not the patient, maybe it's you. Why don't you go find somebody else who has a little bit more experience, a little bit more comfort, and let them try. Because it's not about you, it's about the patient at the end of the day. Sure, we all want to pump out our chest and say, bam, I'm the one that got the IV. But it's really not about that. It's about the patient. I will tell you that once you start becoming successful at IV sticks, you you get addicted to it. It becomes challenging. It becomes fun. I loved starting IVs. In fact, I volunteered for them because it was such a challenge. I can remember IV starts being so intimidating to me, and how frustrating they were when I first started as an ICU nurse, because I missed them all the time. I was a streak player. There were times where I could close my eyes and I could get every single IV I ever wanted. And then there'd be a streak where I don't care if I was taking care of the bodybuilder who had the veins bursting off of their forearms. I was missing everything. And you gotta just keep pressing forward. And seriously, you need to volunteer. Volunteer to try. What's the worst thing that can happen? You miss. You gotta try. No matter what you do, you gotta try. It really frustrates me when you have new nurses that are just starting to do this, and there's an IV start that needs done, and when they ask, hey, would you mind trying to start an IV in bed 2 for me? And their answer is, no, could you get someone else to do that? Could you get, why don't you get Joe over there, because, you know, he loves doing them. He's good at it. You know, Nancy's always good at doing them. Why don't you go ahead and let her do it? Or you make the claim that you're too busy. Now, of course, you just might very well be too busy, but you need to practice. The only way you're going to get better at IV starts is by freaking doing them. It's the same thing with placing an NG. It's the same thing as placing a Foley. It's the same thing as time management skills. Everything in this profession takes practice and time and grade. Do you really think that the nurses that you look up to that have their shiz together, do you really think they started that way? No. No. Not even close. Not even close. I think about when I first started as a nurse, and now my 5th year as a nurse practitioner, and I think about my former self. I think about myself when I first started as a nurse, and I think to whoa, I'm like, am I even the same person? Do I even remember that person? And most of the time you're not going to be. So practice. Keep practicing. Someone asked me about the AccuVein, the what do they call those? The devices that you use, lighting, infrared lighting to to make the veins visible. I have only seen these things through video online. I've never seen one in person. I don't have the slightest idea what the technology is and how it actually works. If it's something that you have access to, by all means, let her rip. I can only imagine that these machines are not cheap, and that not every hospital has the budget for those kinds of things. So if you work in a facility that has these things, by all means, let her rip. I mean, I will say this, it's kind of cheating. I think, I don't know, maybe it's an old school mentality, but I think it's cheating. So if you get an IV start because you had to use some super duper cool piece of equipment, okay, granted you got it and it's all about the patient, but it's a little bit of cheating. Now, I live in that world these days, but doesn't change. Parallel explanation to that is that as a nurse practitioner, I do central lines. I place central lines, I place arterial lines, and all of the lines that I place 90% of the time are with an ultrasound. Ultrasound placed on the skin, you get to see where the vein is versus the artery, and you can watch the needle go through the skin and go right into the vessel. So 100% accuracy, you know exactly where you are. Boom, done. Old school, the old school NPs, the old school docs, they didn't have that technology. It was look and feel. It was knowing your anatomy, knowing your physiology, and basically gauging where your anatomy was and sticking a needle there and hoping for the best. Now, doing central lines in certain areas of the body, you can't use an ultrasound, but you get the point. I don't know about this AccuVein thing. I quite honestly don't know how expensive they are. I don't even want to know. So, someone from the live feed's asking, is that considered a port? Brandy, you're going to have to ask me, what do you mean by, is what considered a port? Julie's saying hospitals can't catch up with the new tech budget. Yeah, so, yeah, the new tech is definitely not cheap, not at all. Smokey saying that they have only seen those AccuViews online as well. No experience on kids, so I'm just scrolling through the feed here. Yeah, so Dave is saying that when they have failed IV attempts after the second try, you have to call in a buddy. I said central line. Oh, okay, Brandy, you're asking if the central line is the same thing as a port. It is, but it's utilized differently, chronic versus acute. So, anyone have any last minute questions, any comments about difficult IV starts before I open up the forum for AMA? To ask me whatever you like. I will definitely answer your question. We'll clarify your question there, Brandy, in 1 second. Just want to give anyone the opportunity to talk about the topic that was posted about difficult IVs. Going once. Talking about difficult IV cannulation. We talked about what's easy, what's good, and what's expected. Going twice, talked about some of the difficult things that can be challenging, talking about pigmented skin, talking about dehydrated or obese patients. Third time's the charm, last chance to talk about difficult IV cannulation. I gave a couple tips in regards to what you can do to increase your success. We talked about pulling the skin taut. We talked about practicing. We also talked about making sure that you locate, and feel what a good vein looks and feels like. Alright, so to answer Brandy's question, Brandy had asked about central line and is that a port? So I talked about how I place central lines. I place central lines throughout the body. I work in critical care. I'm an acute care nurse practitioner. I am trained and credentialed to place central lines as well as place arterial lines in multiple areas of the body. And Brandy wants to know if a central line is a port. And the quick answer is a port is a central line. But a port is something that is accessed in a chronic manner. The central lines that I'm talking about, Brandy, are central lines that are only in the acute care setting, in the acute setting, in the ICU world. So you come in, you're sicker than snot, and you need large bore IV access. You need central access because I'm going to give you lots of fluids. I need to monitor hemodynamic parameters. I need to put you on medication that can be caustic or damaging to the peripheral veins, just the veins that we were talking about. I need to put something into a central vein. Central vein meaning like the internal jugular, your subclavian vein, or your femoral vein. A port is something that is surgically placed in your chest area. And the port can be subclavian or it can be an internal jugular, and it's placed by a surgeon. There aren't nurse practitioners out there that have enough training and education to place a port. So a port is a surgical procedure that is placed by someone who is trained in the art of vascular surgery in some way, shape, or form. If I'm not mistaken, I don't think radiologists can do it, but I do know that general surgeons, vascular surgeons can do it. I can't think of any other kind of specialty that would place ports. And, of course, ports are utilized for long-term IV use, long-term antibiotics, chemotherapy, or trying to think of a third one, TPN or TPN. And these are all very, very specific scenarios. Ports come in a variety of sizes, shapes, and forms. You can have, a port that is literally it looks like a port, and it's accessed using a Huber needle, which looks kind of like an H, Huber needle. Or you can have a good old-fashioned IV that is just covered with a dressing. So, hope that answers your question, Brandy. Nurse Bass, thanks for hanging out with me, brother. Congrats on the baby. Looking good. How's it feel to be a father? Brand new nurse in the ICU, going on a year? Almost a year, I believe. And Brad's a brand new father, so congrats, man. And for those of you that have not checked out Nurse Bass, really? Where have you been on YouTube? You need to go check out Brad on his channel. Nurse Bass, easy. Type in Nurse Bass on Google or on YouTube. Karen saying that temperature makes a big difference when placing peripheral IVs. Ray says, phlebotomist is what the hospital told me to call. I'm just a nursing student in the hospital. Yeah, so if you have a difficult IV stick, many facilities offer a variety of different services. I have worked in facilities that you utilize the lab techs or the phlebotomist, kind of the same thing. You also have an IV team that is completely dedicated to just placing IVs, peripheral IVs, PICC lines, helping with central line placements. So, and they do all of the dressing changes on the entire hospital system. Those are dedicated vascular access nurses, the VAN, the VAN nurse. And there's actual specialty certifications to become a vascular access nurse, a certified vascular access nurse. So, might be an area of nursing you want to go into. Although I probably shouldn't talk into my water bottle. It kind of echoes. Fun fact for you is that when I was in nursing, when I was starting NP school, I actually used to place PICC lines. Just a fun fact for you. Did it for a really short amount of time. It was really cool to do it at that stage in my career. It's not really that cool these days since I now place central lines as a nurse practitioner. Ah, yeah, Brandy. So that explains why your mom has a port. Best of luck to her. I know that's got to be tough. Smokey said had those ports when she definitely was a taxing surgery for her. So sorry to hear about that, Smokey. And Deidre says ports can be utilized for HD as well. Yeah, I guess so. I guess I didn't think of it that way, Deidre. I wouldn't consider those a port. I would just call that a dialysis catheter. But, you know, mincing words, you're absolutely correct. So I also place those temporary dialysis catheters, temporary dialysis, you know. I don't think I'd ever call it a port. That's a new one on me, Deidre. Thanks. I don't think I'd ever call the idea temporary ports for HD until an AV shunt. Yeah, so I mean I still terminology wise, Deidre, I would still call it a dialysis catheter. But you know what? I do call them permacaths. I stand corrected. You are correct, Deidre. I guess when I think of the term port, I think of long-term IV antibiotics, but I guess so. Color me educated. Thanks, Deidre. Does anybody have any questions they'd like to post? Any questions they'd like to ask while we're here on the live feed? Gonna wrap things up. We talked tonight about difficult IV access. Some of the tips, some of the reasons why IVs are difficult, some of the tips that I've used in the past to start IVs, and we briefly discussed a little bit about ports and central lines. Yeah, that's about it. So Gail wants to know where can ports be inserted. I think I covered this just a short minute ago, but we'll answer it again there, Gail. So ports can be placed just about anywhere. Most of the time, ports are placed in areas of convenience, meaning you want to place it somewhere that is usable, accessible, but is also livable, so that the patient can continue on about their day and function as normal as possible without having this bulky IV or dressing getting in the way of life. It's kind of like what a PICC line is for many patients that go home and need long-term antibiotics for months. PICC lines are usually here upwards in the upper arm area, so you can tuck them into your sleeve. So most ports are put into the chest wall, on the right or left chest wall. But the chest wall ports can either be a subclavian or an internal jugular access, and that is completely that's at the discernment of the surgeon who places it. And that had a lot to do with anatomy, physiology, age, what the vein actually looks like, what the patient actually looks like. Are they, big chest wall? Do they have a big heart? Or, do they have a physiological problem that precludes them from one side or the other? For instance, do they have a lobectomy? You don't want to put it on. So if they have a lobectomy, or if they, they only have one lung, or they only have half of their, their left lung, you're going to want to put it on the side where the surgery is, because if you put it on the opposite side and there's a problem and you damage the only good lung, they're in trouble. So that was a long-winded answer there, Gail. Hope I answered your question. Anyone have any other questions before we wrap up the live feed here? Sorry again for bailing on you on the traditional night that we have chosen. Things are happening, I really hope to keep doing the live videos every week. Just a reminder, YouTube Live every Friday night. If Fridays aren't going to work for me or for the tribe, we can always try a different night. We can always move it to Saturdays. I think Saturdays would be just as feasible. I will caution you with my new work schedule. Yeah, having an 8 o'clock start time on a video might be a little difficult for me, working my new 12-hour shifts. I got to get up at 3 o'clock in the morning, folks. That gets a little bit difficult. I think we had one more question here. Deidre says, Jerry, patients with poor vascular status do not use the tourniquet too tight. Oh, Deidre's offering a suggestion here. So for geriatric patients with poor vascular access, don't use the tourniquet too tight. It'll blow every time. Warm packs, if you have time, work. Awesome as a, oh yeah, so as a natural vasodilator. Yes, I agree with the heat packs. Great tips there, Deidre. And tip on the tourniquets, that's a good one. Aaron's asking a question. This may be vague, but difference between calling an NPPA versus an MD on an order clarification. Any questions in general? That's a very vague question, Aaron. I'm not sure if you have a specific scenario that maybe you could clarify. I'm going to answer it with, there is no difference. In my world, there is no difference. I work in the intensive care unit. My responsibilities for caring for patients equates to what the physician does. So if you as a bedside nurse have a concern, have something that needs to be communicated to the provider that is caring for that patient, let me rephrase that. If you need to communicate to the critical care medicine team, which is me and the intensivist, if you need to communicate to the team or to the provider, whatever, however you want to call it, you can simply just page me. In a given day, I am the one who answers all of the questions. I collaborate with my physician all the time, non-stop, throughout my shift, but I have a large amount of responsibility, and I'm the one that makes the decisions. Aaron says, so let's say patient on cardizem drip and BP drops too low, have to stop. Does it matter which one to call or just call the MD? No, that would be a decision I can make there, Aaron. You don't, okay, let's answer it this way. You need to follow whatever policy your facility has. I don't know of a facility that would have a policy where they want you calling the doctor versus the APP. If the APP is part of whatever service that you're calling, then you call the APP, or you page the service. In many hospital systems, for instance, let's take your cardizem drip example. Cardizem drip, you're going to call the cardiology service. You pick up the phone and you say, can you get me whoever's on call for cardiology? In the large facilities, guess who's going to respond to you? The APP. Yeah, we're going to be the ones who are going to respond to you because that's our job. We are the ones who field the questions. 90% of the time, I answer your question. And if not, then, oh, I don't know. Then if I can't answer your question, or if we feel that we haven't solved the problem, then we can recruit the physician for an answer. All of my answers, all of the care that I provide to my patients, I share with, communicate with, and collaborate with my attending physician. So at the end of the day, the physician is going to know about it. But if you need to call something about your patient, there should be no call the physician for these things and call the APP for these things. There should not be a division. If you're working in an area where there's a division, things are going to get lost, things are going to get missed, and quite honestly, patients are going to suffer in some way, shape, or form. Many decisions that have to be made have to go up the echelon of on the decision tree. There are going to be many decisions that need to be made that I am not qualified to make. But it's my job to pass that on or to take that up the chain. As the bedside nurse, it is not your job or responsibility to figure out who you're supposed to call when it comes to a patient concern. You pick up the phone and you call the service who is covering for whatever it is that you're talking about. If you're in a small community hospital and you're calling about your patient, then you call the primary care physician, you call the attending physician, you call the primary service. Hey, I got a thing, you got to take care of it. And if that means that the APP answers the call, then the APP answers the call. We are in a day, the healthcare system in this day and age is becoming universal when it comes to how we utilize advanced practice providers. I like using advanced practice providers because it kind of it gives a good description of what an NP is and what a PA is, and you don't have to say NP or PA. NP or PA versus saying advanced practice provider, I would go with advanced practice provider. So, hope that answers your question, Aaron. We're going to go ahead and close things up here. Does anybody have any last minute questions or concerns? Deidre says that she's the go-to girl for starting IVs. So, strong word, Deidre. Maybe you should have got on. Too bad we don't have like the thing where we can have a guest on YouTube Live. That would be cool. Get on it, YouTube. Want to thank everybody for hanging out in the live feed. Thanks for joining me. Always appreciate you hanging out with me. Every week, YouTube Live, Friday nights, 8 p.m. Hope that you will share this with your friends. Make sure you leave a comment down below. During the live feed, none of your comments will be translated into the comments down below. So if you have any other concerns, anything you would like to say, leave them down in the comments. Hope you should have subscribed by now. If you have not, please hit the subscribe button. Share this with your friends. Let everybody know about my channel. And as always, check your own pulse first.